Hello, this is an interesting case. Many of you have asked, how do you diagnose and treat a cracked tooth? Well, this fellow is a neurosurgeon, and he came in with this tooth bothering him. You can see the crack right here. So how do you diagnose a cracked tooth? Here's a before and after, the endo. This is how you diagnose a cracked tooth. Somebody says, I'm having pain in the upper right, upper left. Typically, a cracked tooth is painful when somebody bites down. They say, it hurts when I bite. Well, I use a cotton tip applicator and have them bite. Say, don't bite real hard because you don't want to split the tooth. But have them hold the cotton tip applicator and just bite on the teeth in the area and see which one hurts. Now, typically the teeth will hurt biting. Many times they'll also hurt with cold if the tooth is vital. Now, the other thing that can cause pain when a patient bites is an abscess tooth. Now, remember, an abscess tooth is often going to be painful when the patient drinks hot. They say, boy, when I drink hot, that tooth lights me up. Well, what kind of pain are you having when it lights you up? If it's abscessed. If it's abscessed, it's going to usually start throbbing and the pain will linger for a while. If it's cracked or decayed into the nerve of the tooth, that pain is going to be short-lived and often caused by, if it's cracked, from biting, cold, hot, temperature. If it's a pulp exposure and just decay into the nerve of the tooth, that's usually going to be sensitive to hot, cold, or sweet. Now let me go through that again. If it's an abscess tooth, not always, but many times, the tooth is going to be painful to heat because you have a gangrenous pulp. And if you've ever seen an animal dead on the side of a road, it swells up. That's from the gas gangrene. And so if you've got a gangrenous or a dead pulp and the tooth is abscessed, that gas doesn't have anywhere to go. If they drink something hot and it swells and it goes through the tip of the tooth into the bone and hurts. And the pain will be prolonged. They'll describe it as a throbbing pain when I drink coffee or hot tea or eat hot foods. And so that's an abscess tooth. This is a cracked tooth. A cracked tooth is going to hurt primarily with biting. If somebody says, I bite down and that tooth hurts, you've generally got a crack. Now, they're not always cracked into the nerve of the tooth. It may be off to the side, and they're just moving those pieces, and that will hurt. So they don't always have to have endodontics, but more times than not, the tooth is going to be cracked into the nerve of the tooth. Now, sometimes people say, it doesn't hurt so much when I bite, but when I let up, it hurts. I suppose that's the nerve being pinched or fluid in the nerve or something like that, but it could be from biting down or letting up. And the other thing with cracked teeth is they often hurt with cold. I haven't had patients say it's so much with hot, but with cold. It may even be with sweet or hot. Throbbing pain, pain to hot, that's going to be an abscess. Cracked tooth pain is going to be biting down. It's just going to be biting down. It may also be cold and maybe hot, but it's going to be biting down. If it's exposure of a nerve from decay or gingival recession, that's going to be pain to cold. Pain to cold. Maybe pain to sweet, but that's going to be pain to cold. So abscess, cracked tooth, nerve exposure. All right, so this person said he's having pain when he bites down, so I'm having him hold this and move it along the teeth. Now, something to remember, in 40 years of practice, I've had some interesting pain. It can be referred pain. Normally it's not, though. The good news is normally the patient is going to be able to say it's that tooth. I had a patient one time and she said, oh, Dr. Cutbirth, this tooth is killing me. You're going to have to take that tooth out, the lower right cuspid. And I took radiographs of the teeth, tapped on the teeth, tested it with cold and hot, and I said, it's not that tooth. She said, it's killing me. You got to take it out. I said, no, I'm not going to do anything to that tooth. It may take me a little while, a day or two, but we'll figure out which one it was. So what you can do in a case like that, if somebody says it's a lower tooth, you can give the patient, if it tests negative, give the patient a mandibular block. and see if that gets rid of the pain. If it doesn't, you know it's a maxillary tooth. When this patient's, in the case of this patient, I had to make wax shims to fit over the teeth to block them and test different teeth with cold, with the ice, or with hot water. Finally found that it was the upper right first molar referring pain down to the lower anterior. So go by your diagnosis. If you test teeth and the teeth are testing negative to cold, hot, biting pressure, don't jump right in just because the patient thinks it's that tooth. Most of the time, they're going to be able to tell you which tooth it is when you have them bite down on something or test it with cold or hot. But occasionally, if it's not making sense, don't do anything until you have a definitive diagnosis. All right, so the second thing I'm doing with this gentleman is testing with ice. Now this is a empty anesthetic carpule with dental floss placed down in here, and you fill this with water and put the wax dental floss down in the carpule and then sit it upright with this end at the top in a plastic cup in your freezer, in your refrigerator. And it freezes that ice, and you've got this floss that lets you pull it out. Now the way you get the ice out of the carpule is you rub the carpule in your hand for a little while like this, just a few seconds, and that heat will melt it on the sides and you'll be able to pull this out. The best way I've found for testing teeth with ice, see, it just pulls right out, and you got that. Hold it with a 2x2 and touch it on the teeth. Now there are lots of reasons for doing endodontics on teeth. It doesn't have to be a pulp exposure. If somebody's got a lot of gingival recession or gingival recession on a tooth and they have root exposure, that can make a tooth hypersensitive. Have I ever done endodontics on a tooth like that? Absolutely, that had no decay, just because the patient couldn't go on with their life because every time they ate something that wasn't just room temperature, it put them through the roof. So that's a reason for doing endodontics. If you've got a deep filling or cavity in a tooth and you're going to place a crown on the tooth, sometimes it's hard to test the tooth just with a provisional crown and know that it's not going to be sensitive when you place the final crown. So if I think there's a high probability of a tooth being hypersensitive or painful to biting when I'm doing a crown preparation, there's a fair chance I'm going to recommend endodontics on the tooth prior to placement of the crown. If you've got root exposure, gingival recession and root exposure, and the tooth's in an aesthetic area, and you're having to do a crown prep down onto that root because it's in the aesthetic area. If it's not in the aesthetic area, don't prep down onto the root, stay in the enamel. But if you're having to prep into the aesthetic area because the patient has a high lip line or for whatever reason you can't do a high water or a supragingival margin, then I don't want that tooth to be hypersensitive once I place the crown. I don't want to make a hole in the crown to do the endodontics because you compromise the crown with that composite in the hole in the crown. So if it's my tooth, and I've had this done to myself, I'm going to want the person to do the endodontics before they place the crown. So it's thoughtful dentistry. You're not trying to do unnecessary endodontics, but you want to do the endodontics at the time you're prepping the tooth and taking the impression, not after you've seated the crown. If you think there's a high probability of a tooth needing endodontics, do it before you seat the crown. Okay, so testing now with ice. And he was reactive both to biting pressure and to cold, which means you've got crack either into the nerve of the tooth or very close to the nerve of the tooth. So you want to be sure to get these teeth dead numb. Watch that video. You know, it's not only infiltration on the maxilla, but it's also intraligamental, and you may even want to block the superior alveolar nerve. I'm placing a rubber dam. but get it dead numb, because after patients had pain with a tooth, the last thing they want is pain from you drilling on the tooth or doing anything to the tooth. They want that tooth to be numb as a post, and there's no reason you shouldn't be able to get every tooth dead as a stone if you use this anesthetic technique. But it's not just infiltration. So if I'm doing endodontics in a crown, I normally prepare the tooth for a crown prior to the endodontics. You don't have to. You can do the endodontics first, but you want to be sure that tooth is dead numb. And you can consistently get teeth absolutely painlessly and profoundly numb every time if you'll use the anesthetic technique I'm describing in that video. You can watch it in dentistrymasterclasses.com. Getting people painlessly and profoundly numb is one of the most significant things a dentist can do for a patient. See the crack going the length of the tooth? See the big crack right here? That's why when they're biting on the cotton tip apicary, you don't want them to bite real hard, because you don't want them to split that tooth right down the middle. It's like a crack in a windshield. You want to get to it before it goes way down into the tooth. If it's past the alveolar crest, then that can be a little tricky, because you can develop bone loss and a periodontal problem there. I would probably go ahead and try to save the tooth with endodontics in a crown anyway, but sometimes if a crack goes past the alveolar crest, they can develop a periodontal defect right there. There's some people these days that say, well, I'd rather just go ahead and extract the tooth and have an implant. Not me. I mean, I love implants. I do lots of implants, but I would much rather have endodontics in a crown. There's a lot of interesting things that people have come up with about endodontics affecting different organs of the body, which there's no scientific evidence behind it. I've had 4 or 5 root canals myself because of sports injuries and cracked teeth, and there's got to be science behind things. So I would much rather have endodontics in a crown than extract the tooth and have an implant if I could, even though I love implants, just because it's so much simpler, less expensive, less involved to have endodontics in a crown. I'm a big fan of endodontics. It's a flame-shaped diamond for the interproximal margins, and interproximally I'm only prepping about a 1/2 millimeter subgingival, and I'm doing the same thing on the palatal. I may only go about halfway down the tooth and keep it in the enamel, because there's really no reason to go subgingival on the palate. And I'm going to prep facially about a 1/2 millimeter to a millimeter subgingival. Never prep into the junctional epithelium. You want to keep it in the sulcus. Round off the line angles on all the way around, palatal-facial, interproximal. Don't go deep interproximally into the sulcus. Just keep it about a 1/2 millimeter, and then on the palatal I'm keeping it considerably supragingival, because there's no reason to go subgingival. If there's no reason to go subgingival, don't go subgingival. And then the facial about a millimeter subgingival. So I'm prepping into the nerve of the tooth here with this 330 carbide burr. Then once I connect with the nerve, remember I've given the intrasulcular injection, which is imperative for profound local anesthesia. You're not going to profoundly numb this tooth with just an infiltration. You've got to come back with an intrasulcular injection if you want the tooth to be profoundly numb. I want that tooth to be as numb as that piece of plastic. I don't want the patient to feel anything, because they're already kind of on edge because the tooth's been bothering them and they're worried about the procedure. So let's get them painlessly and profoundly numb every time. Watch those videos. So once I've prepped into the pulp chamber, I'm going to anesthetize with either lidocaine 1 to 100,000, epinephrine, or Citines 4% plain. Now you can look at the radiograph and tell most of the time if it's a single or a double rooted tooth. If the nerve on the radiograph goes right down the center of the tooth, it's probably a single rooted tooth. And you look at the tips of the tooth, the apex of the tooth on the radiograph, and you can usually see if there are 2 apices, because they're hardly ever in line with each other. It can happen but normally it doesn't. So see, it's right in the center of a tooth. If it's in the center of a tooth, there's probably just one nerve, one canal. You always want direct access to the canal. See, it's right in the center of the tooth. So this is a real-world endo system, and I've got hand files. I use Hedstrom. I really don't use K-files. A lot of endodontists use K-files. That's fine. And then I use this 4-drill system, or this is a scalp file, or this one, which is a XP3DS. This is a single endo drill system. This one works well, and on this case I use this, that, and this. I tend to favor this one a little bit for no good reason. I think other than I'm used to it. These are different size. This is a medium package, and so 9 out of 10 times I use the medium package, which is from 40, 35, 30, and 25. So first you get your measurement, then you always start with a hand file. Now sometimes I'll use a 40 drill to just open up the coronal part of the canal, so the 3-to-1 water to sodium hypochlorite can pool in that opened part. But you always want to do your initial filing with a hand file. Why? It's like the chairman of the endo department when I was in dental school said, if you clean the canal out well and irrigate it well, he said you can fill it with horse manure and it's probably going to work. It's the cleaning and the irrigating that is the most important thing, according to him and other endodontists. Now, I'm not recommending shoddy filling of the canal, but the cleaning and the filling and the irrigating is the most important part. So I use a Hedstrom number 10 hand file first to clean to the apex and irrigate, because the chances of separating a file with a hand file are very slim. But with drills, you're more prone to separate a file, especially the larger drills. If you irrigated and cleaned well with a hand file and you were to separate a drill, chances are 99% it's no big deal. You're not going to have that drill removed, which is a trick, and you can damage the root trying to remove the drill. But you don't have to remove it because it's all cleaned out. On the other hand, if you start with drills and you haven't cleaned it and irrigated it well, and you were to separate a drill in the canal, then there's more chance that you need to have that removed. If you hand cleaned it with a hand file and irrigated it first and were to separate a drill, then it becomes like a silver point, which I've got patients in my practice that have had a silver point endodontic procedure 40, 50 years ago, and the teeth are holding up well. So I'm not advocating separating drills. I'm not advocating sloppy endodontics. That's the bottom line. You want to clean it and irrigate it well with a hand file before you start with the drills. I haven't separated a drill in a long time, but if you do enough endodontic procedures using a drill system, you're probably going to separate one. It's going to be a curved canal, and it's going to be a little larger drill, and it goes around that bend, and it's going to separate. But if it's cleaned and irrigated well, my experience has been you don't have to go back in and have to try to remove that separated piece of the drill. Just leave it there like a silver point. Now, that's my experience. You may want to talk to your endodontic friends and see what they have to say. I'm just telling you what I've seen. Clean it and irrigate it well with a hand file first. Then we're going to clean it, and then we're going to measure it with our apex locator. Apex locators are fabulous. Always bend the hand file before you place it in the canal. Then I'm irrigating with 3 parts water, 1 part sodium hypochlorite. Then I place the file back in the canal. Now, if you're getting a strange reading kind of up and down on the apex locator, you may need to blow a little air in the canal. The water or the sodium hypochlorite in the canal may be affecting the electric part of this read, and you may not get a good read. So just blow some air in there and get rid of most of the water, and you should get a good read. So this is 0.3. You want about 0.5. 0.3 is good from the apex. This is how far you are from the apex of the tooth. This would be 0, 0. So 0.5 is perfect. This is very good. So we know number 12 is 17 millimeters long. Here's my first drill. I'm going to irrigate again with the sodium hypochlorite. Now I'm going to start with the 40. Light pressure and go in and pull it out. In, it stops a little bit, and pull it out. At least 3 times. And just go as far as we can gently. Don't press hard. Then I'm going to switch to a 35. And then at some point I'm probably going to go straight to the 25 and then work my way back up, just keeping it nice and lubricated. Now in this case I used the XP3DS, and it's a single file system, and single drill system. If you use this drill, you're going to fill the canal with a 30 gutta percha cone. Irrigating. The thing about the single drill system, the XP, I've never heard of separating those files. They're very durable. I don't think you have to worry about separating them at all. So I'm trying the gutta percha cone in and going to take a radiograph. This is perfect. Irrigate again with the 3 parts water, 1 part sodium hypochlorite, 6%. The sodium hypochlorite we're using is 6% sodium hypochlorite. Then rinsing that out, drying it with paper points, squirting the BC sealer into the canal, placing the gutta percha cone, using the burner to remove the coronal part of the cone, and compressing it with a plugger. See the crack right there. Then IRM as a buildup, and you want this IRM to be pretty dense. You don't want it to be real milky. You want it to be dense. You can watch the video on how to mix IRM. You want it to be pretty stiff. Surround those line angles, polish your prep a little bit. You can watch the video in dentistrymasterclasses.com on how to make a provisional matrix with pink wax if you don't have a study model prior to the tooth preparation. Then I'm going to wipe it with Tublicid Red, place cord just gently in the sulcus, just enough to retract the sulcus. Then this is a reversible hydrocolloid impression. I always take 2. This is a full tray, and then I follow it with a half tray. And the half tray you can use as a backup for many different things. One is the solid model to perfect the interproximal contact. So here's the endo procedure. It's a crown. So that's the dental minute. These techniques work, and they work every time.
Don't you want to take your practice to the top tier? Subscribe to dentistrymasterclasses.com for an organized library of all the Dental Minute videos, plus many complete comprehensive cases and so many important articles that you can only find right here. New cases are added weekly, and it's only $20 a month. Subscribe today.